name's Ross Overshott, and I'm an old age liaison psychiatrist working in sunny Manchester. And those of you who have been to Manchester may know that there may have been a bit of a fib in the sunniness that I've just mentioned. But certainly sunniness and actually being bright is something that we at least try to establish with people when they have cognitive difficulties, to try to make the most of the cognitive function they have. So how would we know if somebody is experiencing anticholinergic side effects? Well, there's a couple of ways. I mean, we should always be concerned with anybody, but particularly those with dementia, where they're suffering from constipation. But that may be an indication that some of their other medications are actually contributing to that. The same with urinary retention as well. However, one of the questions that I always are keen to ask people is whether they're experiencing a dry mouth. I think that's a really important side effect, and it's actually really annoying, to be honest. The amount of times I've seen people in clinic will bring their own bottles of water because they're experiencing dry mouth. So it's actually a relatively early and a relatively settled one. There's many contributing factors to, let's say, constipation, for example. But actually, there's very few things that cause an almost constant dry mouth. I think the other important thing to really consider of who we should be particularly concerned about are those people who are perhaps frailer, and always be suspicious on people who are actually on many medications, because it's the accumulative effect that's really important. And so whilst we talk about the 3 pointers and hoping to avoid those medications, actually, at the end of the day, 3 points is 3 points. It doesn't matter how you get there. And I appreciate 3 points sometimes in life is good, for example, in basketball. But actually, with anticholinergic burden, it's really something to worry about. There's sometimes an argument that actually 3 points and above is what we want to avoid. But if you have a dementia, I think really overall, we should be trying to aim for 0, because anything could, in some respects, could actually affect the person's cognitive function. That may not always be possible. There may be good reasons why people have to be on certain medications, but certainly we need to keep it in mind in that respect. The importance of anticholinergic burden for people with dementia is something that I first became more of about 10 years ago, but it's something with growing interest. And actually, there's a really important role for pharmacists who often will actually highlight when people may be at risk of experiencing anticholinergic side effects. I've even known some computer and prescribing systems that it actually give an alert when you're prescribing such a medication. I think this is something to really hope for the future for all of us, that we have systems that remind us to try to keep this in mind. For all people, not just people with dementia. There's certainly a role for pharmacists to help educate clinicians, and so we can change our prescribing habits. So anticholinergic burden, anticholinergic side effects can affect anybody, whether you're male or female. There are some conditions that obviously are more likely to happen whether we're male or female, and therefore the prescribing of medication that has an anticholinergic burden may be higher for certain conditions. Hopefully the future will bring medications and treatments that are actually disease modifying. That's the really big hope. But in some respects, developing such treatments will only really be fully effective if we're not still having patients being prescribed medication which is actually affecting their cognitive function. There seems very little point of giving with one hand or taking with the other. Again, even with disease modifying treatments, there will still be people who will have an effect of an anticholinergic burden if they're still on those medications, and that therefore may reduce the benefit they receive from their new treatment. So many ways that we can help improve the management of dementia and other forms of cognitive impairment. From the early part, I think part of the things that we need to focus on is just general good well living and well-being. In some respects, the reduction of the amount of people smoke these days is a good thing. I'm afraid to say that we perhaps haven't tackled people's drinking habits in some respects, which is the next thing to perhaps really focus on. We need a healthier population to help reduce cognitive impairment developing. And that's something in the early part that I think we need to really get across. But it's a difficult balance. One of the other parts of management I think we could really emphasize that actually when we do it well, we do well, is not losing the person. Who is this person? What things have they enjoyed in life? Who do they want to be with? What do they enjoy doing? And I sometimes worry that the health services that we work in, the person just becomes another patient. There's only one of them, and it's always important to stress that, of what's important to that person and understanding. And this is particularly important when their illness develops. further and they become more impaired, of what choices they make. What choices would they have made if they were still able to make some of those? I'm a firm advocate on the whole that people want to stay at home. They prefer not to live in care homes. There are some people who do, who need that support. And that's okay, but I still worry about that we don't advocate enough for our patients in that respect to keep their independence as much as possible. And in some respects, some of the aspects of management I think we could improve on is not expecting things to be perfect, but instead trying to aim for what actually the patient would want to happen. I think at times services, whether they be social services, care services, or health services, are a little bit more focused on trying to avoid complete harm, whilst instead we should be focusing on trying to keep the patient's needs and their wishes in the forefront of our mind.